Welcome to today's Sustainable Sanitation Alliance, or SUSANA webinar. My name is Sarah Dicken, and I'm a research fellow at the Stockholm Environment Institute, or SEI, and I'll be moderating the webinar today. And today's webinar is organized by SEI and SUSANA, and is supported by funding from the Gates Foundation. The webinar today is on the topic of community initiatives for sanitation and making the link to understanding their implications for health. We'll hear from two presenters for 15 minutes each, starting with Juliette Waterkane, CEO of Africa Ahead, presenting on community health clubs for sanitation, and then followed by Manirul Hassan, a researcher at the University of Bonn, talking about the agriculture, water, sanitation, health nexus. And after each presentation, we'll have time for a few questions about the presentation, and then at the end, we'll have time for a more general discussion about the topic. And the webinar will be an hour long, but if we run out of time, please feel free to continue the conversation on the SUSANA forum. You can start a new thread, and both presenters also have some more detailed information about their projects on the forum that you can take a look at. So with that small introduction, we can get started, and we'll start with Juliette Waterkane from Africa Ahead. So go ahead, Juliette.
Thanks very much. Great, thanks everybody, and I really appreciate you all tuning in, and hopefully you can hear me okay. This is a first for me, so I hope that it comes across clearly. My topic, of course, is on community health clubs, which I'm well known for, but I want to broaden the discussion a little bit and just introduce the idea of making community-led total sanitation work within community health clubs in Zimbabwe. I think in the past decade, the community-led total sanitation, CLTS, has become synonymous with most sanitation programs. But recently, some doubt has been cast on the efficacy of this approach. I'd like to present a more holistic development model, which I think does indeed deliver community-led and total sanitation. It's a behavior change model that can achieve high rates of sanitation and much, much more through the use of a community mobilization strategy, which we call the Community Health Club. With the massive effort to achieve the MDGs, the Millennium Development Goals, in 2015, and the start of a new era this year with Sustainable Development Goals, I thought it would be a very relevant time to present this methodology once again, because I think it can indeed achieve not only hygiene and sanitation, but be used as a model which is the part of a whole process of development, whereby WASH is the first phase. So please bear with me as I try and introduce this model in the next 10 minutes. Seem to be going ahead of ourselves on the slides. Okay, so this slide, is somebody doing the slides or am I doing it? Okay, here we go. Right, go back to this. Sorry. So what are community health clubs? Well, a club is just, it's really more than a group of people who meet every now and again. A club attracts people with the same interest and the same vision or dreams. And in this case, it's a vision of having children that survive and prosper through the avoidance of common and preventable diseases. We now know that 88% of diseases can in fact be prevented by safe hygiene practices. So a club consists of people trying to achieve this, working together and changing their ways to have better hygiene. Community Health Club consists of representatives from as many households as possible within a village or an area. There can be anything from 50 to 150 members, and they've all signed up, committed themselves to a course of hygiene that's going to take 6 months, meeting once a week for two hours. It's a typical sort of input. They're not exactly women's groups, as men are very much encouraged to come. It's also true that 80% of the clubs are usually women, because hygiene is something which affects women and involves them the most. I don't know why this is scrolling up the whole time. Okay, here we are. Okay, so just to give you some idea, in the last 15 years we have used this approach in very, very many countries, and Anthony, my husband, and I have been working as consultants. Wherever we've gone, we've more or less influenced the sector to try community health clubs. So in the past 15 years, literally 1.5 million people have been affected by this program, and over 250,000 community health club members. So we do actually have quite a range of experience through different countries, and this is why we're so convinced about it, because wherever we've put it down, it has been very popular. Sorry, next page, right. So the whole program really depends on the membership card. The membership card is a critical component. It actually sums up the whole program, if you like. It's an adult learning process. And so people get the membership card. It's written in the vernacular. This is the English version. But very typically, the card represents 30 or 20 sessions of different topics, as you can see down here. And then the main thing is that every time somebody attends one of these sessions, oops, it's gone off. That's my... So every time someone attends one of the sessions, the card gets signed. And although this sounds like a pretty sort of basic thing, it is actually the sort of need to fill in the boxes, which encourages people to actually complete all the topics. So typically we get 60 to 80% of people completing all the sessions, which is quite a high adherence level. The most important thing is the weekly homework. So for every week, for example, if it's infant care, number 7, the encouragement would be that all children make sure that they've got their correct immunization. If it's more food security, people are encouraged to start gardens that week. So there's small things that they can do for themselves week by week. I don't want to spend too much time on the detail, but just to say that this is critical to the program. As an illustration, I thought I would just share with you one program in Zimbabwe which was particularly exciting. It was in conjunction with ACF and funded by the EU. And instead of just being a sort of like hope for the best, try and get as many households as possible, the target was to involve every single household, i.e. have blanket coverage, which I'm sure, as you all know, as development practitioners, is a pretty high target to aim for, but it was actually achieved. And the other thing was that, and this is why I mean sort of community-led, that every household would have a household member that was in the CHC, and also aim for total sanitation, which in our terms doesn't necessarily mean a latrine. It means that there's no open feces on the ground. It would be cat sanitation, burial of feces, or a good latrine which didn't allow fly access, i.e. it had a vent pipe or cover. So these are our two things here, which are, this thing's running away again. Okay, so just to show you that oh, it sort of keeps going up and down. Okay, yeah, could you? Because it's scrolling up on its own for some reason. Yeah, that'd be better. Thanks so much. Yeah, okay. So just to show you the popularity, I mean, it was actually quite remarkable. If you look at the bottom here, that there were 16,000 plus households, and yet we had 17,000 plus members, which means that there was more than one member per household in community health clubs, so the granny and the mum, or the mum and the daughter. And then also in terms of villages, we had 429 villages, but there were so many people in each village that wanted to join the club that we would split it into 2 clubs if it got over 150 or 100. And then there were 454 community health clubs. So that's just to give you an idea of the uptake and the the responsiveness that there was towards the program. And there were 68,000 people involved, or beneficiaries, if you like. Next slide. Go on. Okay. And so when I went to see the program, it had been running for 4 months, and I was absolutely amazed because I hadn't really seen this before in the many years that I'd seen community health clubs, but they'd actually gone to the trouble to build themselves a shelter where they could meet. You can see it's baking hot country, and there weren't any big trees, and it was winter with no shade. So they'd built the shelter, which I think represents an enormous commitment to the project. And in the foreground, you'll see the pot rack, which was a demonstration pot rack to show members what they should do at their own homes. Go on to the next one. And then at each venue, there was also a latrine. built out of local materials. Absolutely no inputs were given. There was no cement or vent pipe or anything given. But this is how they've improvised a VIP latrine. And you'll see at the bottom ZOD, zero open defecation. That's our kind of local slang for ODF, which they couldn't really get their head around. But ZOD became an absolute sort of rallying cry for everything, and they were zodding this and zodding that. You know, they had songs about ZOD, so it was just a sort of local idea, the same idea as ODF. But over 7,771 latrines were built with absolutely no inputs at all, and we felt that was a very, very strong response. And then, of course, there's the usual Tippy Tap, and you'll see that, again, members had at least one Tippy Tap at home. You know, there was enormous, some people would have a Tippy Tap outside their latrine and also one at the entrance to their house. There were also 79% of the members built new pot racks, and they also had rubbish pits, 78%. So those are the sort of numbers we expect when we're asking people, the community members to change. The best thing, and I know this is really difficult to believe, you need to see these kitchens to actually believe them. The picture here is the outside, an ordinary mud hut. Inside you get this incredibly well organized kitchen, which is all molded out of clay and polished with black polish, shoe polish. And then this incredible display of plates. Everybody had their own plate. This is how they store their drinking water, with a lid and a cup for each person. Everything's beautifully ordered, and in the middle they have a fireplace. And this is a norm in Zimbabwe now. It's become a fashion. It was a traditional way of doing latrines, you know, many, many years ago, which had lapsed. And so people have cottoned onto this, and it's a kind of hallmark of a community health club when you see these kind of kitchens. It's also very good for the environment, in that, you know, if you have a program, or if you have an interest in, you know, deforestation, fuel-efficient stoves can be marketed, and people be taught how to make fuel-efficient stoves to save collection of firewood and that kind of thing. And basically, to run these clubs per year, in this program, it costs $4.42 per beneficiary, i.e., if you took all the members of the family who are benefiting from the hygiene in all those clubs, it came down to $4.42. So our aim is to keep our programs under $5 per beneficiary. And for this, you get a whole range of things, not just sanitation, but good kitchen hygiene, you know, good environment, clean yards, etc. So I just wanted to broaden the debate out a little bit, in that, you know, we're all trying to get sustainable sanitation, and by that we mean hygiene and hand washing. And in recent years, there has been a kind of concern that where countries embraced community-led total sanitation, there was quite a slippage, a backsliding. So whilst it's been probably effective in kick-starting in a fairly sort of aggressive way to get people into sanitation, 2 or 3 years later, after the project, it was found that 92% did not actually meet the original ODF criteria. And so, of course, we can't just sweep this under the carpet and go, okay, well, let's carry on business as usual. We've got to ask ourselves, what were the problems? Why or how can we improve this? And so my theories, my sort of social psychology that I like to sort of work out what makes people change and what makes them stay in a hygienic way. There's a lot of theories that you can put to this. And I think by comparing CHC and CLTS, you can see the difference. And so it's not a bad idea to just try and look and see what we can learn from both ways of doing things. So, for example, in the sanitation, there was small research done by a master's student just very recently, and I just thought this was quite interesting, because it's difficult to sort of unpick this, but he looked at all the CHC members, and of course in a health club there's some CHC members who complete the study, which they've attained their certificate, and they call graduates, that they have a big graduation. So some of them are graduates, and some of them are people that for one reason or another don't finish the study. Maybe they're not there the whole time, or they lose interest, so there's always people that don't excel as much as others. So he looked at the difference between people who completed all 20 sessions and people who didn't complete the 20 sessions, and he compared it. And the way he compared it was when a latrine collapses, as they do if there's a heavy storm or they're not strongly built, or when they're full, i.e. they need to be replaced, how many people went to the trouble, how many households went to the trouble to actually rebuild? And so I think it was very interesting that there's a very significant difference between those who had finished all 20 sessions, i.e. had enough interface, had enough energy to keep going to the club, and those that weren't quite the A team students. They were the less energetic, or the people that didn't buy in as much. But it just says to me that it's really worth trying to get a much higher attendance in programs such as ours, because there's a much better chance that the sanitation will be sustained long after the program. And this was 7 years after the program had ceased. So the other one, CLTS, was 2 to 3 years, and there was this 92% slippage. This was, 7 years, and it wasn't compared in slippage, but you could see that there'd been some sustainability. And also there was another program, which I thought that there haven't been enough programs which compare CHC and CLTS. But luckily there was a few years ago, 2011, Whaley and Webster actually published a paper on this, and it was to look at the difference between CHC areas in Zimbabwe and CLTS. And again, interesting, that the by no open defecation, that means species on the ground, as it were, around. And there was CHCs were a little bit higher here, 20% higher. And here you would say, okay, CLTS is doing much better in that there were many more latrines present in the CLTS areas, until you unpicked it and you discovered that none of those latrines had been built since the CLTS intervention. So this is the kind of thing that, kind of muddies the waters when you think, okay, CLTS is doing well in terms of sanitation, and you find it wasn't in response to the program. And here, the CHCs were vastly more adherent to hand washing facilities, which were present in 70%, was it 60% of the households. So again, I'm not saying CHC is perfect. Of course, we're not claiming that it's zero, we're claiming that it's a high rate of response and that it's more sustainable. So just in case, to just clarify, I know a lot of people know a lot about CLTS, but not a lot of people know about CHCs. Just to summarize the difference between the two interventions so that there can be some discussion and you're not comparing apples and oranges, because there is a very, very big difference between them. In the CLTS, there's a one-day event, which is, if you compare the number of interfaces between the community and the implementers, essentially CLTS has one big day and then maybe, if you're lucky, a couple of follow-ups. But basically, it's a single push, and then they're left alone to sort themselves out. They might come back a year later. And that's very, very different compared to the amount of effort that we put into it, which is we train the trainers, and those trainers are village-based, and we may go back 3 or 4 times during that period to see how the club's going on. But basically, the club meets every single week for 6 months. So that's 20 sessions, 2 hours. It's significantly more sort of push, more drive, more reinforcement than CLTS has wanted to do. And also, in terms of the approach is very, very different. We've got a sort of, I would say, a more kind of liberal approach, if you like, in that we expect people to learn what the issues are, and based on that learning and based on that shared and group experience, they come to conclusions. And that's a sort of informed way of getting people to change, which has slightly gone out of fashion recently. People sort of seem to think that people won't do things because they know what to do, and I totally disagree with that. We found that it's very, very necessary that people know the reason behind why they have to hand wash. They know the reason behind the transmission of disease. By contrast, the village walk, which is basically what happens when the triggering session takes place, it's very much, as everyone claims as well, it's shock tactics. It's the wow factor. It's people going, shit, I didn't realize we shitted so much. It's all sort of dirty talk and shitting. And people are shocked and they're horrified and they have this, kick up their backside to do something. But it's not necessarily very informed, because it's left to them to sort of work out why they should be doing various things, So this is going haywire again. Okay, there we go. Thanks. Down a bit. Yeah. So, again, it's a very different approach. I compare it to sort of like, the reward system and the kind of punishment system. So if you look at the CLTS system, the leaders of the community are empowered to try and sort out their community, and they very often do it the old-fashioned way, which in Africa is, fairly draconian. I mean, there's fines, there's embarrassments, there's people, just thoroughly punished for not cooperating, and I don't think that's a very liberal approach, and I don't think it's really worthy of our sector to encourage leaders to behave like this. I'm not saying they all do, but it gives them the opportunity to actually bully their fellow villagers. And I think it should be voluntary, I think it should be an informed decision, and it should be with the support of neighbours. And it's a different way of approaching things. And also just, in terms of the outputs from the program, I mean, the ultimate aim of CLTS is very much focused on ODF, it's focused on, and hand washing, but it's primarily in the narrow sort of context, whereas our program really seeks to look at it in a holistic way, that anything that can be done in the house, to prevent disease should be done. I mean, it's what we do in our sort of Western ways the whole time. We prevent disease without even knowing it because we have a hygienic environment. And so it's no good just tackling the bathroom and forgetting about the kitchen. What goes in comes out, and you've got to look at, the issues of what goes in, i.e. food hygiene and the general environment, as well as what goes out and where it's put. So, whilst I think there are many, many ways that we can combine the two, they are from a different perspective, and that's got to be understood before people just go, okay, let's just do CHC now and combine it with CLTS. Basically what we're suggesting is that in the 20 sessions that we have in that membership card, there are 2 topics which relate to sanitation. And in those 2 topics, we can actually then incorporate a lot of the triggering or the village walk, or even the different ways that are used by CLTS, but within the context of a club, within the context of people that have actually decided to make a change and have gone through many, many other changes. And then just finally,
Juliet, I'm sorry, you're running out of a little bit of time, so if you could just wrap it up, please, in the next 30 seconds or a minute.
And the last slide, and just to say that putting it in the context of the Sustainable Development Goals, we like to see the CHC as a sort of mobilization strategy, if you like, and a powerhouse, an engine of people power that can actually be used to address many, many different aspects of development, not only water and sanitation, but also address hunger, poverty reduction, good health, equity in education, empowerment of women, protect the environment, appropriate technologies, all these things we are already doing within a health club. But to actually sort of package the SDGs within a framework within the village, which they can all be addressed in one simple group. Our experience shows that the CHC would actually be able to handle that kind of holistic and integrated development. I think on that note, I'd just like to acknowledge my team in Zimbabwe and in Rwanda, and where we have worked, contributed towards this, but particularly the Ministry of Health in Zimbabwe and the partner on the ground, the ACF partner, and the EU funded. We also like to acknowledge the Gates Foundation in Rwanda that is at this moment completing a randomized control trial on the CHC, which will be out by the end of this year. So thank you very much, and that's my contribution. Thank you.
Thank you very much, Juliet, for your interesting presentation. I think we can take 1 or 2 questions now, and then for the sake of time, we'll have more time for discussion at the end of the presentations. So if you'd like to contribute a question, you can raise your hand by pushing on the hand raise icon at the top left, or you can enter a question into the chat window below. We have a question from Henrietta. How did you choose the 20 topics?
That's a really good question. The topics are really related to the context where you're working. For example, in urban areas, we've worked in urban areas in South Africa where there isn't any bilharzia or malaria. We don't do those topics. So in the design of the program, when you're setting up the community health care program, you work with the Ministry of Health or with your partner and you decide what those topics are, what are the pertinent issues, and that varies according to context and country. We tend to go through the wash things more or less and any diseases that can be prevented, but it's very, very flexible.
Move on. We have another question from Bruce Sutherland. In Rwanda, are you working through or with local government health agencies?
Okay, thanks. The program in Rwanda is actually incredible. It's a national program. My husband Anthony was working with the Ministry of Health about 8 years ago, and they were very, very interested in the Community Health Club as an approach for nation building, and they were very concerned not to have anything divisive. So they have put the CHC program into a national program called Community-Based Environmental Health Promotion Program, which is run by the Ministry of Health. So we weren't implementing the program. Our task, we were working to support Ministry of Health to enable better monitoring and quality control so that the CHC model as we designed it was implemented in the classic sort of form. And then the randomized control trial, the evaluation was done by IPA, supported by Gates Foundation. So we were actually there not to implement, but to support.
And we have another question here. What happens to the collected waste over the long term? So when a pit fills up, from Kumi.
You know, we're not really, I think that depends on the context. Obviously, in urban areas, there are a variety of technical solutions to that. But certainly in the rural areas, usually when a pit fills up, it's sealed and they dig another pit. They dig another latrine.
Okay. Great. I think we need to move on for the sake of time, and I know that there's some other questions coming in, so we'll have more time at the end to discuss these questions and the general theme